नोट मत रखिए। और जो रोजे हैं वो जिनको ना आप रखेंगे, यू विल गेट सम क्रेडिट। वो चाहे फ्राइडे का हो, चाहे प्रॉफिट के बर्थडे का हो, या शाबान का हो, जो भी इस टाइप की चीज है। तो इस वजह से ज्यादातर लोग जानते नहीं उसको।
Good evening, sir.
Good evening, Shaila.
क्या हाल है
Sakim.
शैला?
How's life going?
How is Bombay? Bombay is all right?
जी sir, fine sir.
आज का जो है
शैला
सर,
तो बम्बई के मालिक है यार।
Oh, so.
अब वहां से पूरे हिंदुस्तान पे राज कर रही है।
हाँ, इसमें कोई
Sir, what
शक
an
नहीं।
exaggeration, sir.
अब देखिए
And we are
नवाब
so happy. और संडे के साथ तो पूरा
sorry for the
एंडोक्राइन
interruption. We are
सोसाइटी
live
पर
now.
भी
We can
कब्जा
start
कर
with the
लिया है।
session. Hello.
yeah, we are live now, I think.
We are like.
Yes, we are live, sir, now.
Yeah.
With your permission, I would like to start meeting.
Yeah,
Please
sure.
go ahead.
Yeah. So, good evening, everyone. I am Dr. Rajneesh Dedia. On behalf of Dr. Reddy's Laboratory, I welcome you for today's Glucocrinology meeting. So today we have with us renowned faculties to discuss the various aspects of diabetes management during Ramadan. Welcome all respected faculties and thanks for joining the meeting. So at the outset, I welcome the creator of the Glucocrinology meeting, Dr. Sanjay Kalra sir. Sir is eminent faculty. Actually, he doesn't need introduction, but I'll still take the opportunity to introduce him. Sir is consultant at Bharti Hospital, Karnal, immediate past president of ESI, vice president of CEPIS, education editor and deputy chair of International Society of Endocrinology, section editor of Endocrinology, API textbook of medicine. Sir has multiple publications in index peer-reviewed journal, and sir works to spread the endocrine and diabetes awareness across the world. So thank you once again, sir, for joining the meeting. And without further delay, I request Dr. Kalra sir to please take the proceeding forward. Over to you, sir.
Thank you, Dr. Rajneesh, and warm greetings to everybody who is logged in with us today. I'd like to thank the team from Dr. Reddy's Labs, Dr. Neeraj, Dr. Rajneesh, and Sakshat, who have worked tirelessly behind the scenes to bring this dialogue to you. Today we'll be talking about pre-Ramzan dialogues, that is our topic, and we'll be talking about what to do before and during and also after the holy month of Ramzan to ensure physical as well as spiritual health. All of us have patients who keep the Ramzan fast. A lot of things have changed in the past 2 decades. Earlier, there was a lot of confusion. Dr. Zargar and Dr. Jamal Ahmed sir, our senior panelists, will tell us of the time when they used to help their patients keep the fast even with bovine and porcine, plain and lentil. It was so difficult that time. With drugs that if they caused hypoglycemia, they would cause hypoglycemia and keep you in the ICU for up to 3 days at a time, a drug like chlorpropamide. And even at that time, people used to fast. But now we are so lucky. We actually have such good monitoring devices and such good therapeutic interventions that it becomes very easy to make the vast majority of people, of believers, able to fast. I do have a quiz question for all of you. It's been a long time since we asked a quiz. So my question is, in the Gregorian calendar, in which year will we celebrate 2 Ramzans and 2 Eids? Actually 3 Eids if you take the big Eid and the small Eid together. So that is the quiz question. And while we wait for the answer to that, please don't hesitate, type it out in the chat box. In which year will we have 2 Ramzans? In the meantime, I would like to request Dr. Jamal Ahmed sir to take charge of today's proceedings. Dr. Jamal sir, for me, is a teacher. Can we have the next slide, please? There are some people who have worked in Aligarh and they have been lucky to be the Arjuns of Dr. Jamal Ahmed. Dr. Saqib is one of them. I happen to be an Eklavya, but even then, sir has never hesitated in sharing his knowledge, his information, his wisdom with me. And I really treasure the times when I have been able to travel with him, either on a plane or in a taxi. And all the things that I've learned from him, I hope that you will also be able to learn today. Dr. Jamal Ahmed sir is a past professor of endocrinology and director at the AMU Aligarh, and he spearheaded this department to a level of national and international prestige. His contribution is cited in Williams' textbook and in Werner's textbook, which are our main books, and he has been principal investigator in many international multicentric trials. Like I said, he is a teacher par excellence. Dr. Jamal sir, the floor is yours.
थैंक यू संजय। और संजय साहब की एक खास बात है कि ये कुछ जरूरत से ज्यादा तारीफ करने लगते हैं। we have been simply a teacher, and we know that what poor teacher is supposed to do. His job is only to disseminate the knowledge, whatever he has learned from his colleagues or from his seniors. So, as you rightly said, that the month of Ramadan, I think probably will start from the 2nd April 2022 in this country. And there are 2 or 3 things particularly about the Ramadan. One is that it's a mandatory for Muslims to fast Ramadan if there is no contraindication. As I said, there is no excuse. If you are observing the religion, you have to fast if there is no contradiction. There should be clear. And this is one of the reasons that there are many of our patients whom, if you tell them, look here, God has forgiven you not to observe fast because you have got certain condition where it is not allowed. और clear cut बोलते हैं कि आपको ऊपर वाले ने माफ किया, आपके लिए रमजान जरूरी नहीं है. But even then, there are certain number of patients, they don't listen to any doctor. And if they have decided to fast Ramadan, they will do that. So basically, the Ramadan is observed successfully by those people who are disciplined before Ramadan. If you are maintaining a good glycemic control, good blood pressure control, if they don't have various serious comorbid conditions, fasting is not a problem at all in those people. And many of these people who are observing Ramadan for years together, they know how to modify medicine. And most of the time they are able to do it. So our job is basically for those people who can observe the fast to teach them how to modify the medicine and how safely you can do that. And for that, as we all know that pre-Ramadan counseling is equally, and at least 1 or 2 months before Ramadan, we should keep on just identify these people. The second part is that we know that if somebody has decided that he will observe the fast, irrespective of comorbid condition they have got, and they are not listening. So at least our duty is to tell them that, look here, if you have decided to fast, this is the way, please modify your medicine, and you must do intense monitoring of glycemic control during Ramadan. Previously, there was a popular belief about 20 years back that if they monitor glucose, the Ramadan will be broken. It's not there. If they give blood, so there was a lot of misconcept, and there are many of our dear friends and colleagues in this country. For many years, we thought that how to do that. So what we did, that we talked about the Imam, because there are certain people who listen Imam to more rather than to doctors. And then we started teaching Imams also that, look here, this is the religion and this is the thing. And please, when you go to the mosque, or if you do, at least in the Friday prayers, if you are there, there is a small gathering. And most of the mosques, there is small teaching also. So please tell the dear friends who are observing the fast that if you are suffering from diabetes or comorbid condition, these are the situations where the God has told you that you may not observe fast at all and you can go ahead. So as Dr. Sanjay already said, that not only we have to talk about the pre-Ramadan assessment. We have to talk assessment and monitoring during the Ramadan and in the post-Ramadan period also, at least for 1-2 months. They should be followed, that who are the people who maintain their glycemic control, how frequently monitoring was done, have they developed some complications or not. So these are the things which are important. And today in this gathering, I know that many people, and they know better than me, and they will be in a better position to explain. And let us discuss about the various aspects of managing Ramadan. If a person is a diabetic, or if a person has diabetes with various comorbid conditions. So I think that we should go ahead and let us give some chance to our colleagues. And I think the Dr. Shaila Sheikh will start about the pre-Ramadan assessment. We know Dr. Shaila Sheikh, and very well, all of you know. I think the entire country knows. And she is endocrine celebrity in Mumbai. There is no doubt about that. And when she did operation, the huge lady was having morbid obesity. At that time, the knowledge spread like anything. And then I know Dr. Shaila Sheikh will agree that it's very difficult to monitor these people who perform this type of surgery. So she's consultant endocrinologist at Prince Ali Hospital and Safi Hospital. I have got a chance to see Prince Ali Hospital many times in about 15, 20 years back, particularly when the Sadhukot used to be there. He never went with me, but there are 3 or 4 my students who are working as a neurosurgeon, as a physician. So they used to caught me from the Bombay hotel and कि सर आप 1-2 मरीज हमारे देख लिए फिर सोइएगा. तो रात को 4 बजे हमको कमरे में ड्रॉप करते थे बांद्रा की खीर खिला के. So we know that she had many publications in both international journals, and she has got the Investigator of the Year award by Indian Society of Hypertension 2017. And I think she will be talking about the pre-Ramadan assessment. Dr. Shaila Sheikh, please.
Thank you very much, sir. So I am blessed when I have teachers like you.
No.
Honestly, when I have teachers like you, like Zargar sir, I know I'm really blessed, big time blessed. So thank you very, very much. It's always a pleasure talking. I have very limited knowledge on this topic, and it's going to be great to listen to all my teachers over here as to what is the best way to manage our patients at this point of time in Ramadan. Sir already said, Kalra sir said that it has become much easier for us to manage patients because now we have molecules which have a relatively much better side effect profile compared to when both my teachers were looking after diabetic patients. But they did, I would say, a much better job than any one of us put together. What I'm going to talk about today is not only what we are taught about by the textbook. I'm also going to talk a little from, what I have learned from my teachers, and what I'm going to also put across to you is what the pre-Ramadan conversation should be all about. Unfortunately, most of the time when I have realized when our patient is sitting across you on the table, the patient assumes that you do not want the patient to fast. The first difference that we have made in clinical practice now is to actually initiate the conversation of Ramadan 3 months before Ramadan. The moment Rajab starts, and Rajab is already started, we're on 24th of Rajab today. So practically we are having this conversation from the last 20 to 25 days with our patients, asking them, okay, are they planning to fast during Ramadan? When you initiate that conversation with the patient believes that you are interested in what they are going to be doing in Ramadan. So it immediately creates a lot of positivity in the room that, oh, ma'am, yes, of course, I plan to fast in Ramadan, and it is only Rajab. The first, when you ask them, are you planning to fast? The obvious question is, ma'am, I will fast in Ramadan. Conventionally, it was always a thought process, and actually not conventional. Even at this point of time, there are times when before Ramadan, the 3 days before Ramadan, it is the end of Shaban, we are practically working for more than, I would say, 14 hours, trying to adjust medication and getting our patients to where they need to be as far as the sugars are concerned, which is actually a very, very bad reaction. With improved knowledge, with improved understanding, with teachers telling us, no, that is not the right way to go about it, we have now started initiating this conversation. I'm repeating the word initiating, is because when you initiate the conversation, the patient believes you want them to fast during Ramadan, and immediately you are on the same side of the table. The second conversation that we have with our patient is that, yes, I want you to fast during Ramadan if it is safe for you. So I am worried about you. I care for you. I am looking after your diabetes, and it is very important for me that you are able to fast safely so that you are able to fulfill your spiritual obligations and you do not have any problems during Ramadan. 99% of the times you will have a patient who is compliant, and a patient who is actually then willing to listen to you, and a patient who, if you advise them not to fast, will not fast, because as we all know, finally the human body is a gift from the Creator. So when you are talking about this pre-Ramadan, and when you are having this pre-Ramadan conversation with your patient, it is very important that you have both empathy as well as science, both in the same plate, so that you are able to actually do what is good for your patient. Because we always need to understand that finally medicine is the art of that conversation you have with the patient. Conventionally, what are we going to be talking about? Conventionally, we are going to risk stratify the patient, which Saqib is going to be talking to you about. We are going to be advising glucose monitoring, which Sir just spoke about. Sir said the patients who have complications, it is going to be more difficult to allow them to fast, who want potential medication, which is possibly going to cause hypoglycemia and need to monitor themselves. But friends, you would be surprised. We are just in the process of looking at the risk stratification score in our clinic, and it really shocked me myself that almost 25% of my patients in a city like Mumbai do not have a glucometer actually, and they are planning to fast. And some of the conversations when we said that, no, you have to have a glucometer if you're planning to fast, well, like, ma'am, I fast safely. I came to you 2 years back. This year I came back because my sugars were not controlled and Ramadan is coming up. You adjusted my medication. You just adjust it again. I've not had a problem. So why are you so worried now? What has changed? Why are you looking at this data more closely? Why are you filling this form? I mean, there have been and it really struck me that we still have a long way to go as far as education goes. Some of my patients still had questions about whether are they allowed to prick themselves during the fast. We have been telling again and again and again, yes, you can prick yourself during the fast. Your fast does not become invalid if you prick yourself. But again, a lot of education still left as far as that direction goes. I will talk about fluids and exercise and medication adjustment. Again, will be looked after by my colleague. So I will talk about what we would be talking in a Ramadan-focused education program, apart from what my colleagues will be talking about. Now, why are we having this webinar? Why are we repeatedly talking about Ramadan and diabetes? Repeatedly, we've been doing webinars over the last 3 months, trying to reach out to our colleagues, trying to talk to each other as to where it is that we could improve, how we could improve, and where we could make a difference as far as our patients are concerned. And we all know that when we are talking to each other, we are going to learn from each other. We learn better how to form a team that looks after the patients. We learn better how to have a healthcare support system in place. We have learned to have a 24/7 helpline in place during Ramadan, so that patients do not panic, do not feel as if they're somewhere lost when they suddenly see a very high or a very low sugar. There's a lot of reassurance which needs to be given to the patient when they are fasting in Ramadan, to be sure that, okay, they can do it safely. We are increasingly having group education programs with our patients where we educate them in groups. We have realized that when one patient talks to another, under supervision, of course, under supervision, it makes them feel more empowered. An educated patient is also an empowered patient, and an educated patient understands that, yes, I can fast if I am willing to take those extra few steps which are required for me to be able to fast successfully. And with that education, we also tell our patients that now you need to create a rippling effect, and you need to go and educate at least another 5 people out there regarding how they need to manage themselves during Ramadan, irrespective of whether we are looking after the patient or not. So we are practically trying to create a team where patients interact with other people and relay knowledge as to how they should be looking after themselves during Ramadan. It is very important that we have our religious leaders on the same page. Sir just alluded to that. Jamal sir just said that, yes, we need our religious leaders to be on the same page, because at the end of the day, when it comes to a topic which is, Ramadan is not just a month where you fast. Ramadan is a complete experience. Ramadan is a soul feeling experience. It is something which it is an experience which you really cannot explain in words. And a number of people do not want to forego that experience because they are ill. Though, as Sir said, there are a number of exemptions, whether you're pregnant, whether you're traveling, whether you're ill. But in spite of those exemptions, still people are going to be fast. And we as clinicians need to have that pre-Ramadan conversation so that we can make that fasting even safe for patients who you and me conventionally believe are high risk for fasting and ideally should not be fasting. So we have a huge amount of data out there. If you look at the READ data, yes, that shows that Ramadan education did make a very big difference as far as safe fasting was concerned. If you look at some of the education programs, increasingly, which we are targeting for our people, for our HCPs, it does make a difference. And most importantly, what we are increasingly realizing is that we are now making pre-Ramadan the period when people undergo health checkups for the entire year. The Urdu calendar is a lunar calendar. And what we have increasingly realized that a lot of our patients do not undergo health checkups, for example, in the beginning of the conventional year. So we have started doing it in the period before Ramadan so that we can tell our patients, see, you want to fast in Ramadan. I need to be sure that there's nothing wrong with your health. So I need you to undergo all these tests so that you can safely fast during Ramadan. And that conversation never goes to waste as far as your patients are concerned. We have a lot more evidence now. We have a lot more evidence as to how to manage our patients. As we said, we have a lot of new molecules which can be safely used without the worry of hypoglycemia or hyperglycemia. We have newer insulins. We have newer ways of monitoring, be it more often SMBG or whether you do CGMS. And of course, we are now using technology where physical contact is limited to be able to convey to our patients what they need to do during Ramadan. But when does this conversation need to start? This conversation needs to start now. This conversation needs to start actually almost another 3 weeks prior to the now. This conversation needs to start whenever that patient comes to you before Ramadan, so that you can have a detailed medical history, you can do a proper risk assessment, and you can have that conversation about, you can stratify your patient and decide whether it is safe or not for your patient to fast, along with whatever medication adjustment which we will be talking about. When you are talking about medication adjustment, as I said, Ramadan is not only a spiritual occasion. Mind you, Ramadan is also a social occasion. So I always say Ramadan is not only about fasting, Ramadan is also about feasting. Ramadan is also of a lot of connections. And when you talk about this connectivity, the social connectivity, there's a lot of advice about nutrition, which goes in, a lot of advice about lifestyle, which goes in, and a lot of advice which also goes about post-Ramadan, with Dr. Rakesh Sahai will be talking about, because it is also very important that patients do come back to you post-Ramadan. Because if the patient has come to you just with the intention of Ramadan, invariably the patient feels, okay, my Ramadan is done. I believe me, I have some patients who come to me every year just 2 months before Ramadan. They say, ma'am, yes, you adjusted my medication. I was fine during Ramadan. I went back to my old prescription. I am fine even now. But I came back to you because last Ramadan, you told me that every Ramadan may not be the same. And I have to assess myself every year. And I want to be sure that I can fast during Ramadan. I have patients who will adjust the medication according to the previous Ramadan prescription unless they feel, there is something which is not quite right with me. So when you have people with diabetes living with a chronic disorder, you are going to have people who will want to adjust on their own, who will want to do things on their own. And it is, I think, very important that we educate them that yes, you had a very, very successful Ramadan last year, but you need to reevaluate yourself this year so that you have an equally successful Ramadan this year too. So some of the key components which you would look at would be, of course, risk quantification, which we will be talking about in the next lecture, very, very important. And rest of all this, which is up here, which is again equally important when you are managing your patients. Frankly, I love the 7-point guide, but to be very honest, we are looking at this very closely. And we just finished last Ramadan a study where we did do a 7-point SMBG for our patients in collaboration with our colleagues, but it is difficult to get your patients to do a 7-point guide during Ramadan. What we do practically, what we have learned to do practically is, because what we have observed when we are doing our CGMS studies is a number of patients, mind you, do have hypoglycemia mid-afternoon. You would be surprised, but mid-afternoon, you do see a dip in our patients, especially our patients who are on OHs, especially if our patients are on sulfonylureas, however safe, and even our patients who are on DPP-4 inhibitors. So practically what we have started asking our patients is, please check your sugars mid-afternoon and definitely check your sugars before iftar. 2 sugars patients are quite willing to do during Ramadan. What we tell them is, for the first 4 to 5 days, I need to be sure you're not going to hypoglycemia or hyperglycemia post-iftar. So please do at least 3 sugars for the first 7 days. Then I will down titrate it to mostly 2 sugars, and we will see last 10 days what we need to do. The last 10 days of Ramadan, friends, is supposed to be the most auspicious, and people do not like being asked to monitor themselves too closely during those last 10 days. I'm sure both my teachers would let me know better as to how is their personal experience, but that is what my personal experience has been. My patients generally tell me, hey, ma'am, please don't chew our brains and don't call us up over the last 10 days. For the first 20 days, especially the first 1 week, they're pretty compliant with monitoring. They do religiously monitor midday, pre-iftar, post-iftar. Suhoor, they may not monitor, because again, suhoor meal can be a little bit of a problem, different timings. Sometimes patients get up very late, very much near the time when they have to finish having their suhoor. So we realize there's a little bit of a problem over there. When they get up in the morning, again, a lot of them are not willing to monitor themselves. But in these 3-point times, I've found it is much easier to get them to monitor themselves. So at least I am reassured that hypoglycemia, which I'm worried about, and post-meal hyperglycemia, which I'm worried about, in that time frame is relatively well looked after, and I will not have a major catastrophe on my hand if my patient is fasting during that period. As far as diet is concerned, we all know this. I will not get into the details of this, what is written on this slide, but what we are increasingly telling our patients is to make the iftar as healthy as possible. What we are telling them now increasingly is not to have their samosas and bhajias, to be very honest, because most of the patients look at me with that very, very, I would say a very, very, a look which is very non-calent, and it's like, oh my God, ma'am, please. So what we have started telling them now is, you have your date, finish your fruit. And when I'm talking about fruit, we're talking about low-calorie fruit. Finish all the fruit which is there on your plate, and then eat the samosa. Then the samosa will not cause too much of problems for you. That's what we've been telling them. And what we have realized is, by the time they finished eating their fruit and they finished having their protein, and most of the iftar plates will have some kind of protein. It would have a chana, or it would have a ragda, all those kinds of things, or it would have some kind. We started teaching them how to add carbs, how to add complex carbs in that protein, and then have their fried food right at the end. And when our dietitian gets back to them, or when we have conversations, we realize automatically the fried food has started going down and sugars are much more better. We've started telling them to use air fryers. We're increasingly telling them not to deep fry, shallow fry their food. And we try to share recipes. The dietitians try to share recipes with them during Ramadan and try to have some kind of small, competitions amongst them as to which is the best food. Believe me, in Ramadan, my entire Ramadan is looked after by my patients, sending me all kinds of food, which is part of the food competition. So that is how we have been trying to motivate them, to keep them going as far as eating healthier is concerned during Ramadan. As far as fluids are concerned, again, one of the biggest problem about fluids is the high calorie sharbat that our patients have. Again, what we have started telling them is reduce your glass. We tell them have the cutting sharbat. I mean, it is called cutting chai over here. I'm not sure what it is called in the rest of India, but we call it sharing a cutting chai. And we tell our patients, okay, please share your whichever fluid you're having, make it half, take a small glass, keep that glass, and please don't have the rest of the fluid. Oil consumption, yes, reduce definitely. And most important message is, again, this is going to be a hot Ramadan, is have lots of water, at least 3 liters of water. Keep your bottles separate. You have to finish 3 liters of water if you do not have a renal problem, or if you do not have any contraindication to fluid intake like a cardiac problem or renal problem between sunset and sunrise. And whatever activity you are doing has to be done between iftar and suhoor, because most of the patients will be praying Tarawih, which is again intense exercise. And if they are praying Tarawih, they really do not need any more exercise to be done, except of course some of the younger generation is very, very particular about the gym, very, very particular about the activity patterns. All of them are encouraged to do it in the evening time after they have broken their fast. Medication adjustments, they will be spoken about, so I will not go into the details of this, but we all know medication adjustment is mandatory. The last 2-3 minutes of your time, which I will take, is yes, when you need to break your fast repeatedly, again and again. We keep on reiterating, even if you do not have a glucometer, any symptoms of hypo, please, please, please break your fast. It is absolutely mandatory, even if you're 5 minutes away from breaking the fast from iftar. And the reason we keep on saying this is because often what I have seen is that the patient is having an episode of hypoglycemia, for example, at 6 o'clock and is supposed to break the fast at 6:40. The patient promptly goes to sleep and tells me, Madam, I slept it off and I was fine. They woke me up at 6:40. And my worry always is, okay, what is going to be happening in those 40 minutes that we have actually not done anything? Technology has made a very, very big difference. Teleconsultation, telemedicine, telemonitoring have made a very huge difference. Our diabetes educators are much more well-versed as far as educating the patients are concerned. And of course, increasingly CGM technology does make a difference, but a number of our patients still do not like CGM during Ramadan. Still, they feel uncomfortable. They feel as if, though we keep on educating them, they're uncomfortable with something pricked into them during Ramadan. So when you are talking about the positive effects of Ramadan-focused education, definitely it could lead to better glycemic control, better monitoring, better motivation, and as I said, better empowerment is finally what we all are interested in. And if you have a proper education as far as Ramadan is concerned, this does lead to a decrease in HbA1c levels, which we all know is something universal, that if you educate your patients, you are going to make a difference to their lives. So if I summarize what I said, yes, pre-Ramadan conversation, pre-Ramadan education, pre-Ramadan assessment is the cornerstone of having a successful Ramadan experience. You cannot underestimate it. You cannot undermine it. You just have to be sensitive while conducting it. You just have to be a little more empathetic while you're conducting it. And if with the right kind of conversation, with the right kind of motivation, you can have a very, very compliant patient who's willing to have a very, very safe fasting experience, because the patients are now willing to make that difference. They are willing to go that extra mile, and they are willing to now use technology which is offered to them so that they do have a safe fasting experience without having any increased risk of hypoglycemia, or any of the other complications like with your diabetic ketoacidosis or thrombosis, which have been conventionally associated with Ramadan, but frankly, we are not seeing from the last 3 to 4 years. Thank you very, very much for your patient listening. Thank you very much.
Thank you so much. It was really an excellent talk, and there are certain points I totally agree with you, that monitoring for most of the patient is being done at least for 7 to 10 days when they start fasting. And when they say that they're not developing hypo or hyper, they try to miss it. The monitoring really is also important in the last 10 days when the Ramadan is ending. And the reason is that most of the functions, most of the parties, they are being planned in the last few days when the Ramadan is going to be there. When I work in the institute, I think there are not more than 10% people were using glucometer. And since I have retired for the last 6 years now, more than 90% of my patients, they are now using glucometer, because I insist that you have to have glucometer. And for most of the patients, I am distributing glucometer free, so it's very acceptable to them. And I am not paying, but there are many pharma companies. And if I tell them that you have to give glucometer, nobody says no. So that has become really important. You rightly said that when they break the fast, you should always insist that you break the fast with the fruits. बहुत ज़्यादा लोग जिद करते हैं, डॉक्टर साहब ये खजूर खा लें. I don't fight. I say take one. Okay, that will not create problem. And then at least we can tell them that after you finish the fruits, then you reduce the oily food by half. And once they finish the fruit, half of their tummy is already full. So even if they want to take more oily food, they will obviously reduce it. CGM, I know it's difficult, and I can tell you that not more than 5 or 6 of my patients, they really accept CGM monitoring the Ramzan. They said, Dr. Sahab, we are happily doing it. And monitoring, at least they are listening now. They are doing monitoring. Or you really said, I always tell them that at least हमको 3 blood sugar चाहिए. अगर possible हो तो एक सुबह कर लीजिए, एक 12 बजे के आसपास कर लीजिए, एक शाम को 5 बजे बाद कर लीजिए. तो अगर ये तीनों में आपको हाइपर नहीं होगा, you will have very safe Ramadan. So what I'm saying that if we all have a positive attitude, not very rigid, and then just try to manipulate some of the items which are very popular in the month of Ramadan, I think it is quietly acceptable to the patient and they can do better. शरबत का बड़ा फैशन है, शरबत पिएंगे डॉक्टर साहब. हर आदमी को पता नहीं रमजान में कितना शरबत चाहिए. तो मैं तो उनको आप कहते हैं जैसे गेम चेंजर का उस टाइप, उन्होंने कहा भाई ये किस मजहब में लिखा है कि अगर आप रूह अफ़ज़ा का शरबत नहीं पियोगे तो रमजान नहीं होगा. मजहब में तो दूसरी बात लिखी है, अगर सादे पानी से रमजान खोलते हैं तो आपको सवाब ज्यादा मिलेगा. तो जो उनको, हाँ इट्स ट्रू, इफ यू जस्ट टेक प्लेन वाटर एंड ब्रेक द रमजान, उसका क्रेडिट है. तो वहां जब उनको एक्सप्लॉइट करते हैं, हाँ डॉक्टर साहब ये तो सही, हमने भी पढ़ा है कि अगर आप सिर्फ सादे पानी से रोजा खोलिए, रमजान खोलिए तो सवाब ज्यादा मिलता है. तो वहां तक उनको जैसे एक्सप्लॉइट कर लेते हैं, भाई आप अगर उसको फॉलो करते हो, एक एस्पेक्ट फॉलो करोगे, दूसरा नहीं फॉलो करोगे तो ऊपर वाले को तो अच्छा नहीं लगेगा. तो वही अप्रोच होनी चाहिए. एक खजूर का अगर उनकी जिद है तो शुड अलाउ, भाई आप खा लो, कोई बात नहीं. पहले कहेंगे मत खाओ, ब्रेक और फास्ट विद द प्लेन वाटर, टेक फ्रूट, और फिर आपके जो भी पकौड़ी और जितने भी आइटम, हम उसको उर्दू में अलीगढ़ में कहते हैं गलीज आइटम, जितने भी आपको खाने हैं, आपको अगर खाना चाहते हैं तो उसकी क्वांटिटी तो कम कर दीजिए और फ्रूट के बाद खाइए. अब जब फ्रूट्स आपका खत्म हो जाए तो आप खाइए. तो सुन लेते हैं बेचारे इसके. थैंक यू वेरी मच. इट वाज रियली वंडरफुल टॉक एंड थैंक यू सो मच.
Thank you. I'm also going to tell my patient about the water. I didn't know about the water.
नहीं, उसको एक्सप्लॉइट करिए, उसका है क्रेडिट है.
हम बोलेंगे अभी से.
हाँ, उसको सवाब ज्यादा मिलता है. ये बाकायदा लिखा है, हदीस में लिखा है. दैट इज
मुझे पता था, अभी हम बोलेंगे.
हाँ, उनको बोलिए भाई आप
रेफरेंस मौलाना जमाल साहब.
नहीं, रियली कहीं कहीं एक्सप्लॉइट करना पड़ता है, अदरवाइज बड़े मुश्किल हो गए. आई मीन रियली
एग्रीड सर, एग्रीड, परफेक्ट.
चलिए सर, आई थिंक ये
बेचारे को 18 घंटे के फाके बाद पानी पिला रहे हैं तो हम आगे कुछ नहीं कहेंगे.
नहीं, उनसे हमें जरगर साहब ये कहते हैं कि जब आप शुरू में जब टाइम होता बजाय 1 गिलास रूह अफ़ज़ा पीने के, आप 1 घूंट पानी पी लो और फल खा लो, और फल खाने के बाद पकौड़ी खाना शुरू कर दो, तो उनका आधा हो जाता फल से, वो मान जाते हैं. फिर रूह अफ़ज़ा वाला नहीं पीते. हमारे यहाँ तो हम कह देते हैं तो मान जाते हैं बेचारे, इसको कोई बात नहीं. तो साकिब साहब इज हियर, इज young and upcoming endocrinologist. I have heard him talking times back, and I think you belong to Saqib Ayodhya or Faizabad?
It was Faizabad, now it is Ayodhya.
अच्छा, हम तो यार फैजाबाद ही जानते, कोई बात नहीं. I think we'll be talking about he will talk about the risk stratification for Ramadan. You know that the Saqib is the endocrinologist and he is practicing in Lucknow, and he has delivered many lectures. I have heard him sometimes back, and he speaks well. And let us listen to Saqib. Saqib, please.
Thank you, sir. Good evening, everyone, my respected sirs and ma'am. We know that it is very important to know about a patient, that what kind of risk a person is having, so that we can plan. It has been said that failing to plan is planning to fail. So just as we are accumulating more and more evidence that even in those patients where we were placing them as a general rule, like type 1 diabetes is a high risk, but now we are seeing with the evidence we have that even many of them, they might fast, they may fast with not much difference as compared to those who are having type 2 diabetes, or even those who are having just OHAs, which are not having which are not posing so much of risk of hypoglycemia. So yes, we will have to choose, but to put them in a risk category, we will have to give time, and for that we will have to consult them. We will have to ask the direct questions, as ma'am has said, that we will have to start the conversation, and then we will have to involve them that if we are categorizing them, we will be better able to manage their risk of hypoglycemia and hyperglycemia. And the God has given us the options that we must fast if we are not in the in those exempted list, but if we are in if we are in a risk factor, if we can injure ourselves, we must not fast. So we know that we can classify people with diabetes into risk categories, and there might be very different perspective of different people. Like, as I've said, it was an almost difficult task to advise someone who is having type 1 diabetes, but we are now having evidence that from 24 to 47% of those people who are having type 1 diabetes, they used to fast more than 21 days, and they are having an excess risk of hypoglycemia as well as hyperglycemia. But yes, they can fast. So there is a broad variation in the risk stratification. We cannot assume with only 1 or 2 risk factors. We will have to be more specific in terms of risk stratification, for which we are having better and better criteria now. So, and we know that even in those patients who are in high risk, they will fast despite our advices. So still, if we advise them that you are in high risk category, you should not fast, or if they are in moderate risk, and we are advising that you should not fast, but yes, if you are willing to fast, you will follow these kind of advices so that you can make it less dangerous. So it would be better. So care must be highly individualized. A risk calculator is introduced, and there is a flexibility in calculating an individual's risk. More and more risk factors, like we have this variation across the globe, that the timing of fast varies. In summer days, the duration of fast may last from 14 to 18 hours. So a person who is fasting in different geographical area is having different risk. If the patient is having any any assistance in the form of social assistance, in the form of availability of self-monitoring of blood glucose if the patient is having any cognition issue, if the patient is having any dexterity issues, definitely he will be having a different set of risk as compared to a person who is not having these comorbidities. So if we are having this newer risk stratification, this can empower physician. We can empower our physicians that this is a tool by which you can easily categorize your patients, and you can let them know that you are in this category, and if you follow this, you if you are in high risk, you are exempted. The creator who has created you, for which you are doing the fast, doesn't want you to put yourself into risk. He wants you to pray. He wants you to have to offer those furs, but not at the cost of your health, which itself is a gift from our creator. So these are the factors which we consider in risk assessment, like what is the diabetes type and duration. Like type 1 diabetes, we know that it is an absolute insulin deficient condition, so definitely the risk is higher. We can categorize them with type of diabetes, duration of diabetes. We know that diabetes is a progressive disease. With the passage of time, there would be more and more insulin deficit, and we as an Asian population, we know that the development of diabetes is earlier in us, and we know that as early it is, the rate of decay of beta cell is higher when it develops early. So we have this higher chances of having insulinopenia with passage of time. And if the patient is having a long-standing diabetes, his risk would be higher. Presence of hypoglycemia. We know that hypoglycemia unawareness can lead to a catastrophe. The person would not be having those symptoms because of lack of those sympathetic and parasympathetic overactive activation, and he will only be having symptom when he will be having neuroglycopenic symptoms. So when he will be having decreased supply to his brain, only then he will be having the lightheadedness, or he may fall, or he may danger himself by falling. So hypoglycemic unawareness definitely poses the highest risk with 6.5 points. Recent severe hypoglycemia has a risk, has a 5.5 points. If the patient is having multiple weekly hypoglycemia, it also imparts a lesser risk, but yes, it is higher as compared to those who are not having hypoglycemia. Level of glycemic control. So if a patient is having higher level, so it is not that he would not be having the risk of hypoglycemia less. It has been seen that those patients who are having HbA1c to a higher level, they would not be having only the risk of hyperglycemia, but they are also at higher risk of hypoglycemia. The fluctuation is also more in them, and so the risk is higher when the patient is having a comparatively higher HbA1c level at the start of Ramadan. Type of treatment. So we know that pre-mixed insulin has a problem in that if whether we are giving a human premix or an analog premix, the intermediate acting insulin would be having a peak after 6 to 8 hours. So even if the patient is taking any amount at the time of suhoor, the patient will be having a peak after 6 to 8 hours, and at that time the patient would not be eating anything, and the chance of hypoglycemia would be there. So it is similar to the risk of nocturnal hypoglycemia when the patient is taking twice a day premixed insulin as pre-breakfast and pre-dinner injection. So those people are having the highest risk of hypoglycemia, even higher as compared to basal bolus or insulin pump. Once daily premix insulin is definitely having a lesser risk. Basal insulin are having the least risk when we talk about the different insulin regime. Glibenclamide being an old sulfonylurea, they have higher risk among different secretagogue. They have this mechanism of action which makes them more vulnerable for hypoglycemia because of their glucose independent insulinotropic agent. Those who are taking the modern sulfonylurea or short acting secretagogue like ripaglinide, they pose lesser risk, but yes, they still have higher risk as compared to other therapies which is not insulin or sulfonylurea. Self-monitoring of blood glucose. When you tell your patients that God has given this liberty to us that we can break the fast when our health is having any imminent danger, we must not compromise our health. We must not continue the fast despite the dangers of hypoglycemia which we have, and if those dangerous levels are here, whether it is hypoglycemia or whether they are having hyperglycemia, we should break fast. So we will only be knowing those levels when we are having this self-monitoring of blood glucose, especially in those who are having hypoglycemic unawareness, especially in those who are having elderly. So it is even more important in them. So if they are indicated but not conducted, you will be having the highest risk. If you are having those indication but you are conducting but less optimally, which is more common a case in our practice, so they would be at higher risk. But yes, if they are doing it, you can decrease the chances of those risks, especially when they are having a mild risk or moderate risk. Acute complications, when the patient is just having a recent history of DKA or hyperglycemic osmolar non-ketotic coma in the last 3 months, they would be having the highest risk of further complication in the Ramadan period if they prefer to fast. As the history becomes more remote, you would be having lesser chances of repetition, but yes, you would be having a higher risk as compared to those who are not having any such history. If you have macrovascular disease, whether it is an old or acute coronary syndrome, whether you are having coronary artery disease, whether you are having a stroke, whether you are having peripheral arterial disease, and if it is unstable, if it is not controlled, you'll be having the highest chances. If you have lesser GFR, you would be having more chance of hypoglycemia. Like we know that the kidney is a site of degradation of insulin, and also the excretion of different OHAs would be unpredictable, and that would pose more risk of hypoglycemia as well as fluctuations. They would be having more chances of ketosis. They would be more chances of lactic acidosis, and they would be having more chances of complication. If you are having pregnancy, we know that pregnancy is an exemption. Pregnancy, pre-puberty, if you are traveling, if you are sick, it is an exemption to fast. But some people would still demand that they would fast. So in those who are having pregnant but they are within targets, they have lesser risk as compared to those who are pregnant and they are not within targets. Impaired cognitive function or frail, they are having the highest chances of risk. Physical labor, if the patient is bound to do those highly intense physical labor during the fasting hours, they would be having more chance of hypoglycemia. Previous Ramadan experience, though, as Shara ma'am has said, we will have to repeat this exercise every year. But yes, it can give a clue that the patient was having a smooth Ramadan period last year or in the past or not. Fasting hours, so as the number of hours increases, you would be having the higher risk, and that would be added in your risk stratification. So if you put those numbers, and if it is just 0 to 3, you are into low risk, and you are able to fast with those assistance, with those self-monitoring of blood glucose, with those instruction that what you should do, what changes you require for the sake of diet, lifestyle modification, and during the Ramadan period, uh, how the self-monitoring of blood glucose can help you, when you should break your fast, what alteration you require in your exercise, how you should hydrate yourself when you are allowed to drink from aftar to suhoor. So you can empower your patient when the patient is having a low risk, and when the patient is having a moderate risk, and when the patient's score is 3.5 to 6, you can tell your patient that you are advised not to fast. It is a kind of relative contraindication to you. And when the patient is having an score of greater than 6, so there were many things like hypoglycemic unawareness, which itself were amounting to 6.5 number, and they were just enough to put a patient into high risk. So if they themselves are present without any other risk factor, they themselves pose a high risk, and those patients should not fast. We must be firm enough in conveying this fact that you would be having a very high risk when you are deciding to fast. So you are exempted. The creator who has created you has not demanded you to fast. You can do other religious exercises, you can read Quran, you can read them with meaning, you can imbibe those teachings into your life, you can practice those things. That the God is just demanding those things. Unfortunately, you are having a physical condition which is making you not which is making you unsuitable to have this physical exercise of fast. And so the God has given you this opportunity that you can continue to offer other things without fasting for those 16 or 18 hours, and it would be fine. And if your risk stratification improves after Ramadan period, you can compensate for those fast. And if still you are not able to better those risk categories, then you can give kafara, you can give charity with for to other people, which is allowed in our religion. So the risk of by risk stratification, we can avoid the chances of risk, which are hypoglycemia, hyperglycemia. The risk of hyperglycemia would be dehydration and thrombosis. The risk of hypoglycemia would be admission to emergency services, which might be catastrophic. Persistent hyperglycemia, especially in those who are having absolute insulin deficiency, can land you in DKA, which can make a lot of trouble. Physicians must quantify these risks before advising them non-specifically. With the correct guidance, many people with diabetes can fast during Ramadan safely, but they must be under the close supervision. Even if they are having a mild risk, it doesn't exclude the risk. So even if they are having mild risk, the conditions might change very fast. So when you were having a mild category, when you are just having a pneumonia or URTI or any acute decompensation, you can rapidly go into the other higher risk category, and you will have to change your plans for that Ramadan period. So you will have to be under close supervision of a person who can guide you when any such untoward happening happens, the new IDF dark risk stratification defines 3 risk categories, as I have explained, and provides a risk score that includes multiple factors that plays an important role in the fasting decision recommendation for each of those who wants to fast. Individuals who fast against the advice provided by their healthcare professional should still follow expert and detailed guidance to avoid the development of serious complications. So we cannot scold them. We will have to have empathy, even if they have made their decisions against the evidence which we have. So we can only present those events, and most of them they will listen. Some will be following even before advising you. Some will require more and more expenditure of time by your side. But yes, they will almost all of them, they will listen to you. Sometimes they will argue, and sometimes they will accept your suggestions after some time. But yes, it is always productive, it is always rewarding when you will be spending time, when you will be initiating those dialogues, even when the patient is coming to you before Ramadan. So by applying those things, you can make the Ramadan period for those who are faithful a less problematic phase, and it can make this Ramadan period more rewarding for them.
Thank you, Shakib, for explaining in detail how this stratification should be done. You have nicely explained to each and every point. One thing I tell you, frankly, that if during pregnancy there is no problem, because that is the only condition where women listen to the doctor. So they will never insist that they are going to fast. At least I know that if someone is pregnant, if I say that, look here, you don't have to fast because your child is equally at risk, they all listen. They will never insist that they are going to fast. You have already explained that what the risk category and what precautions should be done. Thank you so much. And I think the next in line is my friend Dr. Razi. He will be talking about how to adjust oral anti-diabetic agent during the month of Ramadan, and as far as the diabetes is concerned. Dr. Razi, please. Sorry, some changes there, I think. Sorry, this was not in the program. I think the Khurshid Ahmed Bhatt will speak. You know that he's an endocrinologist at Kashmir, and I think he's now working as a lecturer in the Department of Endocrinology, Government Medical College, Srinagar, and he has some publications. So, Dr. Khurshid, will you go ahead because we are running late?
Yeah, thank you, sir. I feel privileged to present some science in front of teachers who have been teachers of our teachers. So I'll directly go to my part of the talk. As we all know that with the onset of Ramadan, there's a abrupt change in the lifestyle of patients who have got diabetes, and it amounts to fasting for many hours. There is change in sleep pattern, and there is also increase in physical activity in the form of Tarawih prayer and other things. So in order to have a smooth fasting, there need to be a modification in the treatment regimen, because in response to all the things which are going to change abruptly. But before I begin, I would like to say that data shows that around 50% of patients go into fasting without changing their medication. This predisposes them to increased risk of having complications, especially hypoglycemia. So as we will sail through this part of the talk, will understand that there are some, the recommendations are based on the basis of some randomized controlled trials about various classes of molecules, which are usually small trials, and more of this recommendation is based on the basis of experience, and that experience actually is ingrained in the particular mechanism of various classes of these molecules. So if a patient is on metformin during Ramadan, as we know, because of its mechanism, it's insulin, it decreases the insulin resistance and decreases fatty glucose output. Risk of hypoglycemia is least with metformin. So metformin actually does not need any dose modification at the time of fasting. If a person is taking once a day metformin, he can continue with that at the time of iftari. And if a patient is taking two tablets of metformin, he can simply take one at the iftari and one at the sahri. And if a person is taking 3 tablets, then the afternoon dose can be combined with iftar. Usually nowadays, we usually do not see patients taking metformin 3 times a day because we are having prolonged release formulations available. Now, as far as pioglitazone is concerned, there's a small randomized controlled trial about pioglitazone use in Ramadan, and here it has been compared with placebo, and it shows that pioglitazone gives a fair glycemic control in the early, mid, and later part of the Ramadan, and this is without any increase in risk of the hypoglycemia. So pioglitazone per se does not need any dose modification at the time of Ramadan. Now, coming to this apaglutide, which is a insulin secretagogue, but it is different from sulfonylureas in the sense that it binds to a different site, and its onset of action is quick and its duration of action is very short. So we have got some small randomized trials and observation studies with this apaglutide during pregnancy, and it has been compared either with placebo or with sulfonylureas. So the outcome of these trials actually does depend upon to which agent it has been compared. If it is compared with insulin or sulfonylureas, it would appear better as far as hypoglycemia is concerned. But if the same molecule is compared with metformin or placebo, it may show an increased risk of hypoglycemia. So because of its unique mechanism of action, it appears as an effective molecule and an attractive molecule for patients with diabetes at the time of Ramadan. And it is, if the person is taking it 3 times a day, we can give it one at iftari and one at sahri. So as far as these DPP-4 inhibitors are concerned, we have got at least 4 well-conducted randomized controlled trials about sitagliptin and vildagliptin. And in these trials, what they have done, before Ramadan, patients were on sulfonylurea, they have been shifted to DPP-4 inhibitors. Then those were compared with sulfonylureas, and in all these trials, there's a consistent finding that risk of hypoglycemia was significantly less with DPP-4 inhibitors in the form of sitagliptin and vildagliptin as against to sulfonylureas. And so they are very safe. Inherently, these molecules are very safe because their glucose lowering action actually does depend upon it is glucose dependent. When glucose levels are high, they will act and bring it down. When glucose levels are normal, they will not act. So in all these, as the risk of hypoglycemia with vildagliptin is less, and as far as the sulfonylureas is concerned, because here DPP-4 inhibitors are compared with sulfonylureas, risk of hypoglycemia has been found to be less with gilclazide as compared to that of gilmipride and as compared to that of glibenclamide. I think use of glibenclamide in the contemporary period is less likely. We usually do not use these molecules as of now, but we sparingly see some of the prescriptions of patients who had been on these molecules for a long. So GLP-1 receptor analog therapy during Ramadan, there are at least 2 trials about liraglutide, where it has been compared with sulfonylureas as an add-on to metformin during Ramadan. And in all these trials, in all these 2 trials, they have found that there is similar glycemic control, and there's significantly less hypoglycemia with liraglutide arm and significant weight loss in liraglutide arm. So this GLP receptor analog therapy does not require any treatment modification during Ramadan. However, it is very pertinent to say that the actual risk depends upon many of the times a patient is on multiple medications. Suppose a patient is on sulfonylurea and DPP-4 inhibitor. That time the risk of having hypoglycemia is not determined by DPP-4 inhibitor. It's actually determined by sulfonylurea component. So sulfonylurea, there are many studies regarding use of sulfonylureas in patients at the time of Ramadan, and all of these have shown that sulfonylureas actually increase the risk of hypoglycemia as compared to that of placebo or as compared to that of DPP-4 inhibitors, but the risk is least with glucocrinology and more with glimepiride and most with glibenclamide. So actually we have to choose either between glucocrinology and glimepiride, and I'll show the modification that is needed when the patient is on these 2 molecules. Glucocrinology and glucocrinology MR, they appear to be safer as compared to other sulfonylureas. So what is the dose modification? If a patient is taking a single tablet of sulfonylurea before Ramadan and is having well-controlled blood glucose levels, this tablet should be taken at the time of iftari and not at the time of sahri. And if the blood glucose levels are optimally controlled, maybe it may still require a small reduction in the dose of the sulfonylurea. Suppose if a person is on taking 2 milligrams, we may decrease it to 1 or 1.5 milligrams at the time of iftar. If a patient is taking 2 doses, then evening dose, the patient will take evening dose as such, while as at the sahri, they should decrease the dose to half. And as I already said, either we should be using glimepiride or glucocrinology during Ramadan, and glibenclamide must not be used during Ramadan. And now we have got newer class of these drugs, Ignt2 inhibitors, and we already have got some small randomized control control group studies with regards to dapagliflozin and canagliflozin, and we know that they do not act to insulin axis. They have got a unique mechanism of action, and it has been found that in these studies they will compete with sulfonylureas, and as expected, the risk of hypoglycemia would be less with SGLT2 inhibitors as compared to sulfonylurea. But the thing is that they do cause more amount of postural hypotension, and it has been this trial, they have found that around 3.5% of individuals on dapagliflozin complained of excessive thirst. Similar findings are with canagliflozin. Again, we should not initiate patients on SGLT2 inhibitors at the time of Ramadan per se. We should be initiating it much earlier, as was discussed initially, pre-Ramadan counseling and pre-Ramadan assessment that starts 8 to 12 weeks before actual start of the Ramadan. And if our patients are on these SGLT2 inhibitors and we allow them to continue this throughout the Ramadan, we have to take care about their hydration, and we have to ask them to take plenty of fluids during the time when eating is allowed, that is between sunset and sunrise. Again, the hypovolemia was more common with canagliflozin as against to sulfonylurea. However, the hypovolemia was more common with canagliflozin. So if we allow patients to take these molecules, we have to have adequate hydration, and we have to counsel about that. this is more pertinent to the rest of the country, because here in Kashmir, usually even now, I got a lot of snow around, and usually the temperature is lesser as compared to the rest of the country. But still, then we have to ensure adequate hydration. So this chart summarizes what I have said till now. Metformin is safe. Carbos, we don't have any randomized control trial, but we know because of its mechanism, it doesn't require any dose modification. And so is with thiazolidinediones. Sulfonylurea, we have to use glycoside glimepiride, OD dose aditya, BD dose, slow dose we should decrease to half. Ignt2 Inhibitors, no dose modification needed, but we have to ensure adequate hydration. And slightly I'm touching insulin, although it was not in my part, but I thought it is pertinent to discuss it here also. If a person is on insulin, taking once a day basal insulin, they should take it at the time of iftar, and if the blood glucose has been fairly controlled, actually they should reduce the dose by around 30%. If a person is taking 2 doses of insulin, evening dose they should take at iftari, and morning dose they have to take at sahri, and they should again reduce it by means of around 50%. So as I already said, many patients would be on multiple medications, so we cannot use that rule there that they are on metformin and risk of hypoglycemia is less. Risk of hypoglycemia is determined by other drugs also, if they are on sulfonylurea, if they are on insulin. So the patients on multiple antidiabetic drugs, usually they will be having long duration of diabetes, and they may have presence of comorbidities, and they are at a high risk, and we have to counsel them properly, and there has to be dose modification as already suggested. So individuals who are on 3 or more drug combinations, especially those who are on insulin and sulfonylurea, we should reduce both of them, the dose of insulin as well as sulfonylurea before Ramadan, so that the risk of hypoglycemia is reduced. Newer technologies, including continuous glucose monitoring and activity monitoring, may also be harnessed through artificial intelligence to reduce the chance of hypoglycemia in patients with diabetes who are on multiple OADs. So, pre-Ramadan assessment is vital for any individual with diabetes mellitus that intends to fast, and there are advantages and disadvantages associated with different treatment options, different classes of molecules, and individuals, especially who are taking sulfonylurea, which in our case, most of the people will be taking, or insulin, they need dose adjustment before Ramadan. And individuals who are on multiple antidiabetic drugs, counseling is recommended to them, and dose reduction is needed to accommodate for increased risk of hypoglycemia. So with the correct advice and support from healthcare professionals, most people with type 2 diabetes mellitus can fast safely during Ramadan. So thank you. Here I stop, and back to sir.
Thank you, Dr. Khurshid, for clearly explaining how to modify the dose of various antidiabetic agent during the month of Ramadan. And you particularly explained that at least SGLT2 inhibitors should not be initiated in the month of Ramadan. But if somebody is already taking SGLT2 inhibitor before Ramadan, to modify that, ask them to shift in the evening, so that there is, and with sufficient hydration, what Dr. Shaila has stated, that if there are no contraindication, the people must take these food intake. So there is no problem as for the hypo or other hypoperfusion or hypovolemia is concerned by shifting the dose of SGLT2 inhibitor in the evening at the time of the baking the. So I think that without wasting much time, now let us request Professor Rakesh Sahai, and he will talk a very important aspect, the post-Ramadan period, I don't think Dr. Rakesh needs any introduction. He is professor in the Department of Endocrinology at Usmania Medical College Hospital. He has already received various laurels in the form of the awards and publications. So Rakesh will talk about the post-Ramadan assessment or post-Ramadan follow. Dr. Rakesh, please.
Thank you, sir. Thank you very much, sir, for the kind words of introduction. And it's indeed a privilege and honor to be speaking in front of two stalwarts from our country who have been my teachers, Dr. Jamal Ahmed and Professor Jargar. And it is indeed, I mean, we had a very interesting session today. Dr. Shaila has given a very beautiful overview of the pre-Ramzan dialogue, which should be initiated early in the period of, I mean, early, at least about 3 months before the start of Ramadan, so as to ensure that our patients have a safe fasting. I mean, what we are always looking at is that they have this during the month of Ramadan, they can go through a very pleasant and spiritually fulfilling experience if we are able to initiate the dialogue early, and we are able to stratify the risk and make appropriate adjustments in their medication. So I think all the three speakers have spoken very elegantly. They have told us about the risk assessment. Dr. Saqib spoke about all the risk assessment parameters that we have to use. I was and Dr. Khurshid just now spoke in detail about the adjustments in the medication that need to be done. So I think just to I mean, as Dr. Shaila has said, that we are already in the period where we have started initiating the pre-Ramadan dialogue with most of our patients, and we realize that when we are speaking to them early in the much before the Ramadan month, then I think the patients, I mean our diabetic patients are able to understand that the fact that we are helping them to go through the month of Ramadan without having any problems, and without and they are also able to fulfill their spiritual obligations, and that is the important point that we need to highlight to them, and that happens only when you're able to start the dialogue early. Many patients come just a day before Ramadan or the evening before the fasting is to start, and in that situation it is very difficult for us to really speak to them or really discuss with them the various aspects, and many times it's just a matter of a few adjustments in the medication which does not actually serve the purpose. So we need to have a good discussion about not only the risks that are likely to be there, the monitoring which has to be done, the changes in their food habits, how the food habits should be, I mean how the iftar meal has to be planned. So all these aspects could be discussed very well, and that needs to be initiated much early. The dialogue needs to be initiated much early, as Dr. Shaila has very rightly highlighted, and we are, at least in our part of the world, it is the fast lasts for about 14 to 16 hours most of the time, although there is a little difference between summer and winter months, but it's not as big a difference as happens in some parts of the globe. Like you can see here, that Stockholm has a fast of almost 18 hours. Canada has a very long duration of fasting. So I think in some parts of the world it is even more difficult, while in our part of the world I think the fluctuations, I mean the changes in timings are not so great, and most of the time, I mean, even though the fast may be at different times of the year, over a period of say 10 to 14 years, you may I mean over a period of a decade, you may find a change in the it goes through all the seasons, but the change is not very much as we are now just going to hear from Dr. Sanjay Kalra. Has given us a question also on when it is going to be twice in 1 year. It's going to be going to happen. The holy month of Ramadan is going to come twice. So he will we'll be knowing more about it as we come towards the end of the discussion. So Dr. Shaila has actually spoken very elegantly about how we need to discuss about monitoring the dietary advice and the exercise advice, and Dr. Khurshid has spoken about the medication adjustment. So I think while we give a lot of importance to this dialogue in the pre-Ramadan assessment and the pre-Ramadan, which is very important, but many times what happens is that this post-Ramadan dialogue does not happen adequately, and that is something which I wanted to highlight in this presentation today, that as much as it is important to have a pre-Ramadan dialogue and see that our patients are able to fast safely during the month of Ramadan, it is important that we encourage them or sort of motivate them to come back again, because many times it so happens that as Dr. Shaila was saying, I could see many of my patients doing the same, that they come back, I see the prescription again, I just look back at the previous prescription, and that is the prescription which I've given them 1 year back in the pre-Ramadan period 1 year back, and they just come back after that, and after a year now, and again with the fact, and they only tell me that time that they had a safe Ramadan month, and they are now back on their medication, and they are looking forward to discussing about the changes in medication that are required at this time of the year. So I think it is important, because what happens is that once because Ramadan is like for the diabetic patient, it's always like a challenge to be able to fast without having hypoglycemia, without having a problem during the fasting hours. So, and once that happens, once the challenge is overcome, there is a release phenomenon, and that often leads to people not adhering to the diet and the lifestyle that is required during the rest of the 10 months, and therefore it is important that we are able to highlight to them that it is important for a post-Ramadan dialogue is equally important. And just as we are discussing about the risk assessments in the pre-Ramadan period, I think in the post-Ramadan period also it is important that we see how it has been, how their glycemic management has been during that month, and what is going to be the risks in the subsequent months. So it is important that we are able to convince our patients to come back for a post-Ramadan assessment, and we are able to look at how we need to get their medications back to their earlier schedule, and also whether they were able to maintain good glycemic control during the Ramadan month or not. About 50% of our patients are able to maintain good glycemic control. In fact, they have an improvement in the glycemic control, but another 50% may not be showing much of an improvement because of the feasting that is happening in the iftar time. They may actually be having a slight increase in their glycemia, in their HbA1c levels, and it is important in at least in that subset of patients that we focus again on seeing that they are able to achieve their glycemic targets in the subsequent months. So it is nowadays in the last since this risk stratification score has come in last year, it has become very objectivized, and earlier, because we were looking at only a couple of parameters and deciding whether the person has got a high risk or a very high risk, and that was the only categorization that we did, and it was a lot of subjectivity was involved in that. Now with this objective risk stratification that is available, we are able to categorize individuals based on various parameters, not just the presence of type 1 diabetes or the presence of or the use of insulin, which is going to put them in very high risk, but it is also the various other parameters that were looked at as were discussed elegantly by Dr. Saqib in his presentation, and that makes it more convenient for us to understand the risk and to also explain this risk to our patients, so that they are also equally aware of the risks and of the I mean, and they are also able to accept those who have a very high risk are able to accept that they would not be fasting, but they would be I mean going by what we are advising them. Now, coming to the management of, I think Dr. Saqib has discussed very elegantly about the anti-diabetic medications. He has spoken about, the medication that require changes with metformin, with acarbose, with DPP-4 inhibitors, or even with the SGLT2 inhibitors. In some of them whom we are already using earlier. We may not started them at that point of time, but even with all these medications, there is not much of a problem in the adjustment. But the major challenge is with the SUs, where we need to see that we appropriately modify the dose, and also the timing of the medication has to be appropriate so as to prevent the hypoglycemia. And when you're looking at insulin, particularly, we know that those on analogs and those particularly on the basal insulins are much more comfortably able to fast. And particularly, I was part of a study where we looked at the use of the GLP-1 analogs along with basal insulin, and found that combination worked very well in reducing the risk of hypoglycemia, and also seeing that patients could achieve improvement in their HbA1c levels. Now, when you're looking at the important factors that are coming into play in the post-Ramadan period, what we are seeing is that, as I was just mentioning, that after the challenging period of Ramadan that passes, because it is a challenge, it's a celebration also. With that, there is with the celebration of Eid, there's many a times overindulgence during this time, and because of that, we need to assess our patients post Eid. It's very important to a couple of weeks after the Ramadan. It is important to have a post Ramadan assessment, and that would help us in getting their medication and regime readjustments, getting them back to their earlier schedule, because there's going to be a change in their eating habits, and then also the exercise pattern is going to change again from the exercise which was happening predominantly the evening earlier. Many of our patients would start going for exercise in the morning, and that would require a change in the medications and coming back to and so as to ensure that they are able to maintain their glycemic status. And also, we need to highlight to our patients that they need to ensure that they are able to follow their schedule over the lifestyle changes that are done. That are required to be done in the next 10 months, so that they are they are able to get ready for fasting in the next year also, because the progressive nature of the disease cannot be ensured that just because they were able to fast without any problem in the current year, it is important that they are keeping themselves protected from the complications in the coming years also. So I think these are important issues that I would like that I wanted to highlight during the presentation. I wanted to highlight the fact that the post-Ramadan follow-up is often a neglected aspect. There are many components that need to be addressed. We need to discuss about the changes in medication once the lifestyle. They are getting back to their earlier routine, and the changes in the meal timings that are going to happen, the reinitiation of physical activity, the timing of physical activity is going to change. So that is important. That is going to be that needs to be addressed, and we need to assess the glycemic status, the status of various complications, and ensure that our patients are able to carry on the benefits that they gain during the month of Ramadan over the next 10 or 11 months before they get ready for the subsequent Ramadan. So with that, I would like to conclude and thank everyone for the patient hearing, and hand over the mic to the chairpersons.
Thank you so much, Rakesh. I really said that the post assessment is important after Ramadan. And what we are doing now, that when we ask the person on Ramadan and change the medicine, I just do the medicine. At the same time, we also tell them that look here, when you finish the Ramadan, start celebrating. And if you have not have any complication during the month of Ramadan, you shift your medicine that you were taking before the Ramadan, start doing exercise, and must do certain parameters to assess the renal status and glycemic status after Ramadan period also. I think I'm sorry, Sanjay, we are late by about 4 or 5 minutes. Now we will start with the two great friend of mine, Professor Zagar and Professor Iqbal.
We have questions in the chat box, sir, for them.
Yeah. You can go ahead, Sanjay. I think now you do it.
If you can just introduce them, sir, Dr. Jabbar and Dr. Zargar.
स्लाइड तो दिखा दो यार. जरगर साहब को इंट्रोड्यूस करने के लिए मुझे स्लाइड की जरूरत तो खैर नहीं है. मैं सिर्फ इतना कह सकता हूँ कि when I joined PGI Chandigarh in 1985, so Zargar Sahab was already there, and you know the type of hammering and type of labor that you used to do in the PGI Chandigarh. I think after 3-4 months, I was so frustrated. I said that, look here, I am going back. So it was because of the effort of Zargar that I could stay. He said, no, don't worry. And this was for the first time, don't worry. Because we used to have at least 5 or 6 seminars in a week. And हमारे जो पहले एस साहब थे, उनकी खास बात थी, जैसे मान लीजिए सेमिनार मिला जरगर साहब को, हम बैठे हैं, कभी कभी वो कहते थे अच्छा आप रहने दीजिए, आप बताइए कि क्या बोलना है आपको. That used to be surprise here. Anyhow, we all know that Professor Zargar has established the Department of Endocrinology in Sherry Institute. At least I know. He has been director of the institute for many years. He has got a lot of laurels. I don't have to repeat it. And I think we have become too old to introduce ourselves unnecessarily. So with a great credit to Dr. Zargar, I think we are all going to be benefited. Then the Professor Jabbar, you know that he's the professor at the head department of endocrinology, working at Trivandrum. He has been a postgraduate teacher, and he was chair of ISKCON 2017, organized secretary RSSDI 2010. He has got a number of publications, and he has been a regular examiner for various universities, DM and DNB. So with these two stalwarts, I think some of the questions are already there. I hand over mic to Dr. Sanjay Kalla.
Dr. Zargar and Dr. Jabbar, thank you for being with us. Dr. Zargar, sir, there is a question regarding risk stratification and also risk of hypoglycemia. Does age play a role during Ramzan?
Understandably, you know, Sanjay, everybody has to understand a couple of things. One, older the person, the chances are that diabetes has been there for a longer time. And it will not be diabetes alone. You know, a person who is a younger guy who has diabetes of 2 years duration, or a 75 years old guy who has a diabetes of 30 years duration. By end of the fact that he is of that age would mean that there are good chances that one, as Sakib was saying, by then he must be on insulin or multiple drugs because he will have had beta cell apoptosis almost complete by then. Two, he will definitely, you know, be hypertensive by then. 2/3 of people in our country who are diabetics are hypertensive. At least if nothing else, he will have significant atherosclerotic disease, and at least systolic hypertension would be there. This does not suffice. Both these conditions would progressively compromise his renal function. And otherwise, also independent of any known sickness. With age, eGFR starts dropping down. So magnitude of the renal dysfunction will be there. And on top of that, if his nervous system is incompetent, his autonomic reflexes are affected. The response to hypoglycemia would be defective in terms of symptoms, as was already very elegantly talked about by these youngsters. So if that stage, a person is on a therapy that is a potential of causing hypoglycemia, that is a huge issue, because it will not only be hypoglycemia, it may do a damage beyond hypoglycemia, particularly in a setting why you do not have much of a familial support. Maybe 20, 30 years back, parents, grandparents, children living together. But today, Sanjay, everybody going helter-skelter for a job. Many elderly people being lonely. I am living in a neighborhood where, where there's a rich colony by my side. Literally, everybody has a multi-million buck house. Either one or two people living there. And every time they come to me and they tell me, every time they brag that their son is in London, a doctor, a professional, an IT guy, or in Paris, I feel so uncomfortable that why are they repetitively telling it to me? Because it is hurting me, because nobody is taking care of them. Every time, it's so difficult talking to the drivers, talking to a maid. So all these factors need to be kept in mind. And as Sake very rightly said, if you have a long diabetes, chances of hypoglycemia, unawareness increase. And with that, directly going into neuroglycopenia rather than being in a state where you will respond to symptoms of sympathetic overdrive and do something about it. As like break the fast. Say, okay, so I'm not feeling well, so eat something. He gets palpitations, he gets sweating. So sort of signals. So yes, we need to be careful in elderly people, and an episode of hypoglycemia may be an episode of precipitating a dysrhythmia, precipitating a cardiac event. That all things need to be kept in mind.
Thank you, sir. Dr. Jabbar, there is a question about SGLT2 inhibitors. Supposing someone is already on SGLT2 inhibitor therapy and is doing well, should we continue during Ramadan? And any caveats, any concerns, any checkpoints we should be aware of?
Thank you, Dr. Sanjay and team, for the wonderful platform for us. And I think this question is very pertinent. I think, theoretically speaking, if you go through the idea of recommendation, the concept is better to discontinue. But of late, people are coming with a lot of encouraging data to continue to use SGLT2. Okay, that is the data which is documented in the literature. I can tell you one more thing. Now, Kerala, the temperature is very, very hot and humid. Okay, so what I feel, personally, in Kerala at least, we should be a little bit careful before going for Ramadan, if you are taking SGLT2. That is my view. But theoretically, of late, there are data which support. But certain group of patients, you should be very careful. As Sargar sir was discussing, the age factor, those who are having little renal problems, elderly individuals definitely, and certain other drugs also, you should be very careful. So answer to your question, probably is useful, data are good, but you should be very careful depending upon the climatic condition. That's my answer for the question. Thank you, Sanjay Bhai. Over to Sanjay.
Thank you, sir. That makes sense. Dr. Zargar, sir, if you could continue with this discussion. Dr. Jabbar said that in some patients, we would be better off changing the drug. So one question is, when should we change the drug? Should I change it 3 days before Ramadan, 3 weeks before Ramadan, or should I change today?
Sanjay, first I must tell you that if a person has been on a stable dose of any SGLT2 and has been reasonably well controlled and does not take any other additional drug or insulin, in most individuals, we may not need to change it. Only the timing might be changing. You might have to take it in the evening rather than in the morning, because after iftar, you have a sizable time for breaking the fast, offering the prayers, taking dinner, and then further offering Taraweeh. And so there's a sizable time, you're going that period. And whatever is the non-fasting period, yourself well. Understandably, if there are any contraindications, they are rather limited now today. Many times when you give these SGLT2 inhibitors, if a side effect has to occur, if dehydration has to occur, if any hemodynamic instability has to occur, it invariably occurs in the first couple of months. But if a person has been on the stable dose for a good period of time, usually not a hassle, might change the timing. But if there is a reason to change, it cannot be done overnight. All of times are like, it is no rocket science. When you change a drug, new euglycemia cannot be maintained overnight. And that has to be discussed at a pre-Ramadan counseling. And we usually start pre-Ramadan counseling 2 to 3 months earlier, because the appointment schedule is 3 monthly. And what I have found out that all those establishments where you have been giving this counseling for a long time, with years life becomes easy. And initially, when we started counseling, we created these words, pre-counseling. I'm just like, nobody taught us, nobody told us how to change things. And you made a beautiful statement right in the beginning. We have those primitive tools to treat patients with. Imagine now that you talked about chlorpromamide, 72 hours half-life. You have a hypoglycemia, you have to admit the patient for days together on IV drip, even glibenclamide. And those primitive bovine and porcine insulins, which are used for more than a decade and a half. Mechanizing that was rather difficult. But today life is relatively easy. But whatever the elegance of therapeutic armamentarium available to us, none of us is good enough to make a judgment. You have this treatment today, tomorrow I change it for a month, this will give you the same results. It just does not happen. So it has to happen. But I must tell you, Sanjay, at large, I desist making major changes in treatment, except, what Khurshid was talking about, insulin doses, sulfonamide dose, fine. And one very appropriately what Jamal Saab said, but insist that after Eid, please start your pre-Ramadan regime. Don't come to Dr. Rakesh after 1 year, and then he feels that whatever changes he has made last year, the patient is continuing the same treatment today. If that change is to be made, make it a couple of months early. Otherwise, I'll tell you, particularly I'll tell you Indian mentality, our patient mentality. You truncate somebody's insulin, oral hypoglycemia, and a couple of times gets a good blood sugar. Then he remains in that illusion of good sugar without insulin, making that basal insulin half for months together. And then you take another few months to establish his control. By then the next Ramadan is there. And now you are talking to us about 2 Ramadans in 1 year. So you can imagine, when will we have that time to give him a good control? So minimize this and emphasize. I tell you, Rakesh, still many people would not come for this post-Ramadan thing. So people who come, they'll come for everything. So they are basically excellent patients, then 1/4, 1/3. Otherwise also. And those who come only that episodic, they continue to, I call them episodic visitors. So Dakir Saab, मैं तो कहता आप तो दर्शन करने आते हो, इलाज करने नहीं आते हो. So, things like that. So insistence on what Jamal Saab said, that for God's sake, after Eid, go back to square one, even if you don't see me. But precisely do what you were saying.
And that question is actually, yeah, and you have answered it very emphatically, that if there is good control during Ramzan, after Eid, you have to go back to the old dosage. Absolutely. Because you will go back to your old meal pattern. Unless you say that
Sanjay,
you're not going
again, we discussed it last time also. Not only go back to the therapeutics, but go to back to the habits. It's a misnomer that people get starved during Ramadan. You should see that feasting part is never being discussed. Wait for this month for those feasts. And many times it continues for a while after Eid also. Would you?
Dr. Jabbar, one question. Would it make sense to add a tablet of acarbose or voglibose to whatever regimen is going on and to give this tablet with iftar?
Of course, that's a good option, probably GP option. Okay. If the blood sugar is okay, you can continue, you can modify the drug. But what is happening during Ramadan is very funny. Those who have worked in United Arab or Arab countries, they're all using lot of calories. Okay, maybe in the form of carbohydrate, maybe in the form of fat. So, see, what is happening is overeating. And during Ramadan, they're taking a lot of rest also. See, in Arab countries, after your sahur, the people are going for sleeping. Okay, so there is no caloric consumption at all during time, and you are taking a lot of calorie during night time. That's also, I have a personal feeling that that should not be the principle in Ramadan fasting. Okay, so your question is it sensible? Probably sensible. There is no doubt about that, since you are taking a lot of carbohydrate. Probably little gel practice management. Okay, yeah.
Dr. Shaila, if we could take you in, supposing someone is on a long-acting sulfonylurea, let's take a modern sulfonylurea like, let us say, glyclazide sustained release, maybe 60, 90, 120, and patient has been taking it with breakfast usually as a once daily dose. How will you change during Ramzan?
The decision will be made depending, one, on the patient's HbA1c, patient's previous control, and what kind of history we get. If the patient's HbA1c is fine and the patient is well controlled, then we would reduce the dose and switch to evening timing, that is, tell the patient to have it at iftar. We were part of the Ramadan study, sir, which was done in India and also was done in the UAE. And it was seen with good monitoring. If the patient's HbA1c is well controlled between 7 to 7.5, a 50% reduction of the dose and switching the time to evening at iftar time, your patient does not have any increased risk of hypoglycemia during the day. What's interesting, sir, that there is also a study which compares glyclazide with gliptins. And in that study also, actually that study was sort of just brushed under the carpet, but that study also showed that glyclazide had a lower incidence of hypoglycemia vis-a-vis even gliptins. And our personal experience has been that gliptins are not completely as safe as we perceive, at least during Ramadan. We do see hypoglycemia even with gliptins. So we reduce the dose by half, switch the timing. And if the patients are uncontrolled, for example, if the patient comes to you with an HbA1c of say 9, 8, all our patients don't come to us 4 to 8 weeks before Ramadan. So a lot of our patients come to us 2 or 3 days before Ramadan and they want it to be adjusted. In those patients, then we would most probably not reduce the dose. We would just switch the timing and tell them to continue it. If the patient is asymptomatic, we allow them to fast during Ramadan. If they're symptomatic, as a result of the hypoglycemia, then we see whether we can add some medication. But as Sir said, we are very hesitant about adding any new medication just before Ramadan, because it invariably leads to problems during the fasting hours. We do not know the patient's sensitivity to the new medication. There would invariably be some kind of problem. So if you're adding any medication, we prefer doing it at least 4 weeks before Ramadan. If the patient has come just before Ramadan, we would just tweak his medication, reduce the dose depending upon his HbA1c, or continue the same dose with change of timings.
Thanks. Dr. Saqib, there are some brand names, some fixed dose combinations which come as scored tablets. Glimepiride plus metformin, also glyclazide XR plus metformin. Then there are others which are not scored. So is this common in practice? Would it be rational to say, let us say I am taking metformin plus glyclazide twice a day, and then now Ramzan has come, so I just make it half a tablet in the morning before suhoor, and I continue that one tablet at night after iftar. Does this make sense? And do you use this very simple strategy with your patients?
If it is a scored tablet, then it can be welcome. If it is not a scored, then definitely a combination therapy would not be predictable. So definitely we should refrain from just doing this kind of habit.
So do look at the brand names. That is a personal suggestion. And not only look at the brand names, look at the tablet that is in front of you. You will find that there are a few brands for both glyclazide and glimepiride with metformin, which are scored. The majority are not scored. So choose a scored one, and that is quite easy for you to use, for you to explain. and also for your patients to use. Dr. Khurshid, there was this study, 3T study, and then 4T study also in insulin. But here 3T means time taken to teach. So time taken to teach about Ramzan modification. You have a busy OPD, you have patients coming in tens and hundreds. So Dr. Khurshid, how do you manage time? Over the next 1 month, can you share some best practices with us?
Yes, sir. As I already said, we have to gear up ourselves 2 to 3 months before, because we have to start the dialogue, and we may need to see the patients again, because this would help them. So we have to gear up. The way we are having this dialogue, we have to start much earlier in our patients, and that way it helps a lot. So regarding this, we could use the diabetes educators and give them some simple tips and other things, so we can use our auxiliary staff and have some sessions with many of the patients, so that in the quickest possible time, many of patients, including their attendants who are along, and using many of the videos outside our these waiting areas, so that they get the idea what is needed to be done.
Dr. Rakesh, you are now serving as president of the Endocrine Society of India. Any suggestions for how to strengthen this dialogue and take it forward?
Yeah, I mean, for strengthening the dialogue, we can do many things. I mean, there are many things that can go into that. But just to answer the previous question which you were asking just now about how you can do it fast. I mean, how you can ensure that you are able to cater to the large number of people that we see. And what I just wanted to add is that Dr. Shella gave us a very good overview of all the points that need to be addressed. But one important thing is I like to add is that asking them about the previous year's Ramadan experience also actually gives us a lot of insight into what they already are aware of, whether they had any problems during the previous Ramadan, if they had a comfortable fasting experience, and then taking that forward from there, we can quickly give them additional information and help them in understanding better. So I think that is one important aspect that we should always do, is ask them about their previous Ramadan experience and then take it ahead from there, and that gives us a lot of help in terms of quickly being able to address the issues that we need to actually address. We'll know what are the issues that need to be addressed, and we can focus on those issues. And
we should begin from this year's Ramzan. So when the patient comes back to us in the month of Shawwal, then the first question is, how was your experience? Was it good? Thank you for having cooperated with us, and we'll do the same thing next year. We'll do it better. If it was not good, there must have been some shortcoming on our part. We'll fix up next time. We'll begin planning your Ramzan fasting in the month of December only. So we'll begin from the post-Ramzan dialogue, and we'll ensure that the next year is much more pleasant.
Absolutely.
If Dr. Neeraj or Sakshat are with us, I was wondering, Dr. Neeraj, Sakshat, are you aware of any, Dr. Neeraj is there, are you aware of any scored tablet, glyclazide plus metformin? Any brand name that you're aware of?
We have the scored tablets. Plus, there are some new SKUs also launched to ease out the titration part. 90, 120 mg possibly would be helpful.
If you're not too shy, perhaps you can tell us the names.
Yes, sir. So the Reclite tablets are now available with 90 and 120 mg also.
And Reclimate is scored. Yeah, even Glyme M actually is another scored tablet, glimepiride plus metformin. And even I was not aware of these things earlier. So it is a good idea to be sort of vigilant also with what your pharmacy is giving you, what is not being given. Today, this morning, I had a patient who had been taking a 70-year-old lady. I had prescribed DHEA, dehydroepiandrosterone, and her daughter-in-law had been giving her Dufeston for the past 7 months at age 70. So these are things, and the good thing is that I caught it, and the bad thing is I was not able to prevent it. So I should have been more vigilant.
Sanjay, you said a very powerful statement today only in my clinic. I saw a patient से डॉक्टर साहब आपने बोला था आधी टिक्की खाना, इससे तो पूरा वो इधर उधर ज्यादा से ज्यादा बिखर जाता है. And he said it turns into an ash. So then I realized, I had written one brand, glycoside 60 milligrams in the morning. And I told him to come after 3 months. But I told this guy, do a blood sugar after 6 weeks and talk to my counselor. And the counselor finds out that fasting blood sugars are slightly on the high side. He asks him, take a half tablet in the evening also. No fellow is in doldrums. What a coincidence. Thank you so much. कि आप ये riddle solve कर दी. It incidentally happened this morning only.
And Dr. Jamal Ahmed sir, last question, and that is Dr. Zargar's fault that he's keeping us beyond time, because he reminded me of the riddle. So the question for Dr. Saqib and Dr. Shela is, in which year will we have 2 Ramzans?
I don't know. Frankly speaking, I don't know.
I will pass the question to Dr. Zargar sir and Jamal.
2033.
मुझे नहीं मालूम. Really, honestly, I don't know.
चला हमसे एक नहीं हो पा रहा है, दो
2033.
2033 or 2030 also, because every year it advances by 10 to 11 days.
Yes.
So most probably 2030 we will have 2 Ramzans.
Beginning of the year and end of the year.
Yeah, January and December. And
Sanjay,
in that year,
best of the
Eid might
Ramzans
fall
in
on Christmas.
Kashmir are during winters.
Sir, yeah.
Best Ramzans are in Kashmir during winters. वो 8-9 घंटे का total दिन होता है. So I was in a meeting one day and there was a guy from Canada talking, a Muslim chap. He said, in my area, do you know what was the riddle? कहता है शाम होती ही नहीं है. See, so how do we determine when to break fast? And then they had found their own ways of how. He said, on an average, the light lasts 20-22 hours, for 3-4 months in a year. So such people must have a real difficult issue. But I think, Khurshid and me is relatively simple job. Summers are not that hot and days are not that huge. And it's walking towards more comfortable time from April to March to Feb. So life is going to be for a decade or two rather comfortable.
For the next 15 years or so, it will be more comfortable, yes. On that pleasant note and on that happy note also, that things are going to be much easier, and we are grateful to God for having given us all these modern diagnostic, modern monitoring, modern treatment options with which it becomes easier for us to help our patients. On that note, I'd like to hand over back to Dr. Jamal Ahmed sir for the vote of thanks, and then to team Dr. Reddy's.
I really thankful to entire group of Dr. Reddy's laboratory for bringing this as an important issue. Plan is going to be started on the 2nd April. I think each one of you really educated us, discussing all the various aspects of Ramadan. We'll talk about the pre-Ramadan assessment, Ramadan and post-Ramadan. Very important. One thing, Sanjay, I tell you really that the people, Ramadan is basically a commitment. I said that it's a commitment to fast. It's a commitment to fast during the month of Ramadan. You cannot have the excuse that I will do 10 days later on. Only in special circumstances it is punishable. So it is always said that you fast during the month of Ramadan if there is no contraindication. The other thing is also correct. Those who want to observe the fast and if they are healthy, they will do it, whether it is a month of May or June, or whether it is month of winter. For us who are the Western UP, the winter is really very hot. Temperature goes up to 44, 45, 46. But those who are determined, they will fast. Those who do not want to fast, they will not fast in the month of December and January. So it's all there, it's all commitment, and the people, they will insist on observing the Ramadan. This program is very good, and I really appreciate the effort of Dr. Sanjay Kalla for bringing some of us together. and this important issue.
Mubarak, everybody. I said Ramadan Mubarak to everybody.
Ramzan Mubarak in advance.
Thank you.
Same to you, ma'am.
Thank you. Dr.
Assalama.
Rajneesh.
Thank you. Happy Ramzan to everybody.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you.
Goodbye, sir.
Good night, everyone.
Goodbye.
So with your permission, can we call it a day?
Okay. Thank you so much.
Thank you. All right then. Good night.